Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. I'm your host for our program tonight on upper extremity, neck and back problems. The success of our program tonight depends on you, the viewer, so please call in with your questions. The telephone numbers, as usual, are at the bottom of the screen. I'm pleased to welcome our panelists, Dr. Brad Kuzel, an orthopedic surgeon with Essentia Health, Dr. Glen Rudolph, an orthopedic surgeon with Orthopedic Associates of Duluth, and Dr. Juan Styliaras, a neurosurgeon with St. Luke's Neurosurgery and Associates. And our medical students answering the phones tonight are Jake Krogstad from Iota, Minnesota, Leah Larson from Bemidji, Minnesota, and Megan Shea from Burnsville, Minnesota. So now let's begin our program on upper extremity, neck and back problems. I'm going to start furthest away with Dr. Juan Styliaras. I don't know if I'm still having trouble with the name. I'm hoping I'm getting close, but I believe that you're a neurosurgeon. Do you want to tell us a little bit about your practice and what neurosurgery is and the kind of things you do, please?
So neurosurgery in general is one of the subspecialties for surgery that deals with cranial and brain pathology, both traumatic and in terms of tumors, and obviously with spinal pathologies, both again traumatic and degenerative. So anything that has to do with deformities or tumors, whether it is within the central nervous system in the brain or the spinal cord or within the spine, that is my scope of practice.
Very good. Dr. Rudolph, can you tell us a little bit about your practice?
So I'm an orthopedic surgeon here in Duluth at Orthopedic Associates, and I'm primarily a general orthopedist. I do specialize in shoulder surgery, but I handle all types of bone and joint issues.
Dr. Kuzel?
Ray, thanks for having me here.
Oh, thank you
again.
for coming.
I work at Essentia Health in Duluth. I've been here for 7 years, and my practice is upper extremity, so that means shoulder to fingertips. Over the last few years, my practice has really tended, I take care of more shoulder problems than the other areas of the arm, but I love them all. So,
I think what we'll do, thank you very much for the short introductions. Those are nice. I think the patients appreciate them. We talked a little bit earlier, Dr. Ron, about the cervical stenosis, spinal stenosis in the cervical spine. Let's chat a little bit about that. Can you tell us about it a little bit? And then I'd kind of like to know how we all fit together in that.
right.
I mean, it's interesting because even though a pathology can, manifest itself within, the neck, it doesn't always come across, like the symptoms don't come only in the upper extremities or in the neck. And that's what is interesting. People don't realize that because the spinal cord, as it starts within the cervical spine and it goes down the spinal canal, if we have pathology within the cervical spine, then it can actually affect other things that, for example, gait, it can provoke gait instability. So many patients will come to the office and they think that they have a problem with their lower back because they feel that they cannot walk straight, that they feel that their legs give way. And they will get a lumbar MRI and they will see maybe a disc here or there, like certain disc herniations, but that is not what is the actual cause of the problem. The cause of the problem becomes after a very detailed and focused physical exam, we can start seeing that there are some abnormalities in the upper extremities. And then when we do appropriate imaging of the cervical spine, we actually find that the problem is at the cervical spine where there's either spondylosis or some kind of degenerative process or a disc that's pushing onto the spinal cord, and that is what is causing the symptoms.
Is this an area that you fellows get involved in also with orthopedic surgery, the spinal stenosis type things, or is that pretty much straight neurosurgery?
There are orthopedic surgeons who do a fellowship in spine surgery, who will, operate on cervical, thoracic, lumbar spine problems. But most of us tend to not do spine surgery if we haven't done a special fellowship in it. But I do think, at Essentia, I work a lot with Dino Terzic and Dr. Durga. We're pen pals because sometimes patients they'll come to see me and they have a lot of pain in their arm, but it just doesn't really seem right, doesn't fit the classic clinical exam that a patient will have for a rotator cuff tear or something like that. And then, on closer inspection, they have weakness where they shouldn't have weakness, and then we get an MRI of their cervical spine, and they have a large disc herniation or stenosis where the nerve root, or kind of narrowing where the nerve root comes out of the spinal cord. And so I think there is a lot of crossover, and it keeps us on our toes.
That's kind of been my observation, that there has been that. We have questions, so we'll jump into those. I think we'll start out, Glenn, if you want to take this one. I often find myself waking up with tingling in my arm and fingers. Should I be concerned? And that's a pretty narrow history, or broad history, actually. There's a lot of questions with that. So
there's several things that can actually cause that kind of numbness and tingling. There's compression of the nerves as they go in, as they traverse some of the joints in your arms, in your arm, and then there's also sometimes people just lie on their arm and cut off the blood flow to their arm, and that can get you to wake up. Two of the most common nerves that get for lack of a better phrase, they get smushed in the arm is the ulnar nerve here at the elbow, and then the median nerve, which is here, and they cause different fingers to go numb. But those are two of the most common things that we see. The other thing too, and should you be concerned? Well, yes, over time it can lead to significant problems with musculature, so losing the muscles in your hands over time. But it never hurts to get an opinion. So if you, it's one of those things where I recommend if you have that happening over and over again, and it's something that doesn't basically improve over time, then you probably should have it looked at.
probably wouldn't hurt for them to go see their primary care physician or someplace and start in on that.
Because it can actually be something more serious.
Yes.
So sometimes symptoms do cross, and if someone has bilateral hand numbness and tingling, and if someone starts noticing also their hands intrinsics distally, the strength of their hand is weaker, that they start dropping objects, they start having problems buttoning their shirts, or they're seeing that their handwriting is starting to change. It could be one of the early signs of cervical myelopathy, which is cervical spinal cord compression, which is what we were talking about earlier. So some of these symptoms, actually can cross different kind of disciplines.
And I think probably just to carry that a little bit further, besides just a spinal stenosis or myelopathy, that could also be something else growing in there that we wouldn't want to be there also, a cancer or something like that.
Yeah.
Does old trauma, Brett, in the, so you see the x-rays, I've seen a lot of x-rays. Mm-hmm. There's always this ring of degenerative changes and so on, and the spinal canal will look narrow. Does old trauma cause problems with that, or is this, do we tolerate those degenerative changes pretty well as far as the spinal cord is concerned?
I do think it can, certainly, and probably like a lot of other areas of the body. And I like looking at cervical spine MRIs, and I'll look at them when my patients come in. I think it's kind of the straw that breaks the camel's back sometimes. Something is building and building over time, and then bam, all of a sudden you have symptoms.
Yeah,
just like carpal tunnel, the same thing. You don't get that overnight, but people will say, yeah, it's been bothering me for 3 months, and you can tell it's probably been kind of building over time, and then it reached a threshold where all of a sudden, now I have a lot of symptoms.
Yeah, I agree. Like, the body has an amazing capacity to compensate and compensate and compensate and compensate up to a point where it cannot do it anymore, and then it's very rapid deterioration.
Right. But with the earlier question, I would say that most of the time, when you have numbness in your hands at night, as Glenn said, it's related to how we're sleeping. A lot of times we sleep like this, and we're kind of compressing the median nerve at the wrist, and the ulnar nerve is that funny bone nerve at the elbow. It kind of stretches around that bony prominence on the inside. And so a lot of times the primary care doctor will say, why don't we try some braces initially? And oftentimes braces can be pretty good at night for carpal tunnel symptom early on. Right.
And even the ulnar nerve, just with lying on your back with the nerve down on.
I found just using a pillow actually works, because it prevents you from deep flexion or deep bending of the elbow.
Good points. Chiropractors, physical therapy. We're involved with a lot of things that happen to the musculoskeletal system. When should a person see a PT or a chiropractor for their neck pain? And is there a process in there where that should happen? And my thoughts are, I should probably be looking at that person. Maybe you guys need to be involved at somewhere along that before we go down those roads, but I don't know for sure. So, any comments?
Well, I think that is an area that can start early on and can start with the primary physician, and starting with physical therapy, especially if it's musculoskeletal in nature, the symptoms. There's certain symptoms, and some signs that we can see on exam. Tenderness to palpation, exacerbation or relief of symptoms with just motions and flexion, extension of the neck, or even like the shoulders. And so from those, we can see that it is of musculoskeletal nature, and so physical therapy will help. And then if in spite of physical therapy, we start seeing that the symptoms do not improve but start worsening, or we start seeing the addition of other neurological deficits or anything else, then we need to start looking a little more carefully and start looking into getting some imaging studies to see what's going on.
And my personal experience, again, I talked about the primary care physician, and you guys can respond to this. We send you quite a few people that need things done, but the chiropractors are also front line and are, for some people, a primary care. Mm-hmm. And I think there's a lot of referring that they do to you. They know when they need help also. Is that a fair assumption?
Yes.
Yeah.
Yep. Spinal fusion. What is that?
So spinal fusion, and that's a very broad term, but basically what it means
Let's
is...
talk about the neck.
In the neck.
Okay.
So it talks about providing stability either in a segment that has instability, whether by trauma or degeneration, an unstable part of the cervical spine. And so you do the fusion to prevent any further destabilization and to be able to make sure that you protect the spinal cord. But in other cases, for example, in anterior cervical decompression and fusion, the reason we do the fusion is because the reason for someone having radiculopathy, which is the nerve compression, is from a deteriorating disc. And so that disc needs to be replaced. And when you take it out, then you do have to put a graft in its place to provide, again, the stability for the spine. And that is where the fusion comes in.
We talked a little bit earlier, there's some new, I don't know how new, it's been around 15, 20 years probably, but replacement of the disc. Is that something that's works well or not?
Well, it's one of the new modalities, and it doesn't have as much of a history. We don't have that much data like we have for the cervical fusions. Cervical fusions, we have data for up to 20 to 30 years, and we have experience, and we know that it works, and we know what kind of complication rates they have. The most rigorous and best studies that we have for disc replacement are the ones that can show that they're as good. The theory behind it is that because they provide still a little bit of mobility, they prevent adjacent level disease, meaning by allowing that segment to still have some mobility, it doesn't force the level above or below to have hypermobility and further deterioration. But there hasn't really been really good, robust evidence to show that yet. I think it's a good thing that we're having a lot of studies out there, so we have to see over the next 5 to 10 years if that is true or not.
The other part of this question, thank you. The other part of this question is how active can a person be after a spinal fusion? And I've had many patients with spinal fusions that go on and live pretty active lives. So there's a healing time, and any one of you can jump in and answer this, I suspect. But it takes a while to heal, and then they should be able to resume basically normal activities with maybe some limited range of motion.
Yeah, I mean, we're not doing this for people to be couch potatoes. We're doing these to provide, again, quality of life and make them and help as much as we can for them to go back to their normal life.
They can play tennis and shovel and curl and all
Many
of
of them, yes. But of course, it depends on how many segments are fused, right? Like if someone gets fused, a big long segment, you actually do lose some mobility. But especially in the neck and the cervical spine, people don't realize that the vast majority of movement, rotational, and everything is in the top two elements of the cervical spine, C1 and C2. So when you do fuse at levels below, the loss of motion is much less.
Anything to add?
No, I think we're all of our goals are to keep
Yep.
people moving and without pain. So yeah.
Okay, you two, either one of you, when should I see a doctor for shoulder pain? Let's go there. The shoulder.
Whenever you have shoulder pain, it's it's one of those things. I think people a lot of people know that they can. They know that they can, that there's things that they can do to try and make their shoulder feel better. You can take ibuprofen, things along those lines. I think if you've had trauma to your shoulder, so if you've fallen, especially this time of year, you fall on the ice. We see a lot of people, I think, who have fallen on the ice and they have rotator cuff tears or shoveling.
What's a rotator cuff?
So that's a group of four tendons that attach to the top of your humerus, so the arm bone here, and the whole goal of that muscle tendon complex is to keep the ball in the socket. So basically, it rotates the ball, but its goal is to keep the ball in the socket. When it tears, you can lose function. A lot of people actually have rotator cuff tears and they don't even know it. Their body, like we had talked about earlier, just compensates for it. But sometimes, again, the body compensates, and then all of a sudden you push, you pull, you're shoveling snow, and all of a sudden it tears enough that now you don't have balance in your shoulder anymore, and your shoulder doesn't work. And so that's a good example of when you'd want to go see your doctor about that.
The other one that I find is a problem is when you almost fall, or you slip and you throw something really quick.
Right.
Absolutely.
So the other piece then, Brad, as we get older, the cuff is fraying as we age.
That's correct.
Yeah, okay, that's what I was afraid of.
Yeah.
So as you get up into your 70s and 80s and beyond, there's a lot more difficulty and a lot more problems with that shoulder, it seems like.
Yeah, I think rotator cuff problems they're very common in folks mid-40s through their 70s and 80s. You don't typically see younger patients with rotator cuff tears in their 20s or 30s. So it's very common. That said, our folks are very active into their 80s, and they want to have a good quality of life, and they want to, be able to do the things they want to do, and so a lot of times we're taught that folks don't necessarily do as well as they get older with things like rotator cuff repairs, but that's actually not been my experience. I think a lot of patients through all age levels can do well.
Ron?
And just to add, I'm sure my colleagues agree with me, like that patients should not be afraid to come to see a surgeon. We're not we're not trying to do surgery on everyone. We don't try to fuse everyone. Actually, I'm sure that you guys, in your own practice, we try our very best to achieve the goals without surgery. And we do have an entire armament of conservative treatment, whether it's injection, whether it's extra physical therapy, whether it's traction, whether it's other modalities. We do try everything that we can to see, if we can get a patient without, to get improvement in their symptoms without surgery. Unless, of course, there's something that we see is very, very dangerous that, we have to address surgically. But in the vast majority, we do try to get our patients through and get improvement in their symptoms without surgery.
I totally support that. That is exactly true. So then when you get them and you're not going to do surgery, when do you use physical therapy or maybe the chiropractor?
Oh,
to circle around to the other question.
First line. Physical therapy is absolutely first line, always.
Yeah, I can agree with that. Epsom salts, do they do any good, or is it placebo?
No, I think they help. I tell patients with hand swelling is probably the most common reason I'll have patients use Epsom salts. It's basically like putting your hand in the ocean. So osmosis helps kind of pull fluid or water off the hand, and so when you put in a really salty Epsom salt bath, it kind of helps pull water out. And so it should help with swelling, especially in the fingers. When the fingers have swelling, they lose some motion, and so it should help. If the swelling comes down, it should help the finger motion improve. And this is common after people fracture their wrists or have a hand injury, from falling down.
Yeah, I agree. I
saw your hand up.
Yeah, it's interesting because there was a study that showed that with Epsom salts, you can actually, through skin, absorb a lot of magnesium, and it's one of those minerals that people have depletions and don't know that they have depletions that cause a lot of the symptoms. And so that's part of the reason why Epsom salts do work.
Glen, yoga. How valuable is yoga in maintaining spinal health? It's a tough. It's a spinal question. It's not a shoulder question, but where do you see yoga in orthopedics or in neurosurgery?
I'm a huge fan of yoga. The biggest thing here is the vast majority of the population, and I'm talking across all walks of life, we have very poor flexibility. And so anything that you can do to stay active, to keep yourself flexible, so stretching regimens, which yoga is excellent for, and anything that strengthens is going to be extremely helpful. As far as neck and back dysfunction, I mean, stretching is absolutely helpful in maintaining range of motion. It's the stiff people that end up injuring things when they have to move fast or they almost fall, or those are the people that get hurt. It's the ones that are limber who don't suffer those injuries.
And I do think that a lot of the stiffness, we're all built differently. I've always had stiffness in my hamstrings, and that can lead to low back problems. And kind of a stiffness on the inner part of the leg, that can lead to arthritis in the knee. So when joints aren't balanced, and I think there's a huge role for yoga in the joints, whether it's the knee or shoulder, the back, to help keep things balanced and help, part of it's keeping you strong. And I think there's probably some preventative role.
And everything isn't interconnected. Biomechanics dictates that from the legs, from the knees, from the hips, it affects posture, then it affects the spine. So everything does get interconnected.
Absolutely.
This one I don't know about. So what is a double crush syndrome? And can you talk about it? I don't know what it is, so help me out.
So I commonly deal with it with carpal tunnel syndrome, and you hear about it with carpal tunnel syndrome. And so basically the idea is that if the nerve starts in the brain and then it goes out through the neck, through these canals that can be pinched sometimes, then it goes down through the shoulder region, down into the arm, and then through the carpal tunnel. If the nerve is pinched at the carpal tunnel and you decompress it, if you do a carpal tunnel release, that patient might not see relief. If they don't see relief, it could be because it's also pinched up here at the neck. And so that'd be the double crush phenomenon.
I understand.
I kind of tell people it's like if you're driving down to the Twin Cities and you're on 35, if you get rid of construction up by Duluth, but there's still construction down by the Twin Cities, it's still going to take longer to get there. So that's the idea.
All right. Thank you.
Yeah.
Inversion tables for spinal injuries, are they worth it or not?
Spinal injuries, no. No. If they have spinal injury, no. That's a big no-no. It's only for degenerative, and it is for patients who do have radiculopathy, who have some foraminal stenosis, meaning the small hole from where the nerve comes out from the spinal canal. If that is of limited space because of disc degeneration, then it can help, but not if you've had spinal injury. So whoever asks that question, please don't go on an inversion table if you have spinal injury.
Yeah, you just really don't see them. Don't. Glenn, what can you expect post carpal tunnel surgery? What's recovery like?
We kind of have the rule of basically most orthopedic surgeries take an entire year to recover from fully. Carpal tunnel is not that long. Most of my patients recover from their carpal tunnel surgery within approximately, the skin incision will heal after about 2 weeks. And then it takes them a few months after that before their hand is really feeling like it was before. You can sometimes get some pain in these two regions of your hand, where it's called pillar pain after the surgery. That can last usually up to 6 months if you get it. The vast majority of my patients do not have experienced that pain at all. But overall, people recover from it probably within around 2 to 3 months.
How about ulnar nerve? What do you do with someone with the fourth and fifth and the ulnar nerve? Do you transpose that, or what do you do with that?
So that is, it's kind of you can kind of make that determination. Usually if the nerve is really stretched, then you would want to consider transposing the nerve. A lot of times they don't seem to be significantly stretched, and you just release. If they have adhesions or scar tissue over the top of the nerve, you can sometimes just release that, and that will actually improve that. Most of the time we end up transposing the nerve, however, because it's actually stretched in the canal.
Peripheral neuropathy in the feet, but hands and arms are going numb randomly while driving. So this is a person with peripheral neuropathy. Hands and arms go numb when they're driving. Any connection with the neuropathy, or is that something else? And Juan had
it could be part of the neuropathy, in which unfortunately neuropathy does mean intrinsic damage to the nerve and the nerve ending. So there's no cure for it. But if it's coming only at certain times, when, for example, like they're driving, it could be because of the positioning or the flexion that they're doing on their neck. So it could signify that they're having some kind of cervical pathology. So it could be that they're having cervical spinal stenosis. So they should get checked out.
Very good. Thank you very much, gentlemen. This has been a really fun evening. I've enjoyed this. I want to thank our panelists, Dr. Brad Kuzel, Dr. Glen Rudolph, and Dr. Juan Styliaras, and our medical volunteers, Jake Krogstead, Leah Larson, and Megan Shea. Please join Dr. Paula Turmulin next week for a program on upper GI problems when her panelists will be Dr. Amy Greminger, Dr. Daniel McKee, and Dr. Teresa Smith. Thank you so much for watching tonight. Happy holidays, Happy New Year.